For your esteemed presence on the grand inauguration of the Palliative Care Unit by Techno India DAMA Hospital, a healthcare medical center under the august leadership of Senior Clinical Oncologist Professor Dr. Shyamon Sharkar. I, Dr. Pai Kumar Roy, Chief Dietitian and Critical Care Nutritionist of Techno India DAMA, extend a warm welcome on behalf of Techno India Group to all the doctors and colleagues present over here. Now, I would like to express the gratitude to our chief guest and requesting them respectively to take their chairs on the dais. So, at first, I would like to call upon the name of Professor Manushi Roy Chaudhuri, co-chairman of Techno India Group. Next, Dr. Shorab Ghosh, medical director of Techno India DAMA Multispecialty Hospital, Healthcare and Medical Center. Professor Dr. Shyamol Sharkar, Senior Consultant, Clinical Oncologist, ex-HOD of Calcutta Medical College, President of All India Palliative Care, AIPC. Dr. Manish De, Pain and Palliative Care Consultant, Saroj Gupta Cancer Center, Thakurpukur. Dr. Shrikant Atreya, Senior Consultant in Palliative Medicine, Department of Palliative Care and Psychology, Tata Medical Center. Dr. Rana Mukherjee, Senior Consultant, Laparoscopic and General Surgeon by training primarily in UK, ex-Medical Director of Woodlands Hospital, ex-Vice President on Project and Strategy at Apollo Hospital, Kolkata. Thank you, respected dignitaries. So I would like to invite Sharmani and Sweetie for the felicitation of our honorable guests, respectively. Professor Manushi Roy Chaudhuri, Madam. Sir, Dr. Shorab Ghosh, sir. Professor Dr. Shyamol Sharkar, sir, chairperson of today's scientific session. Our distinguished speakers, respectively, Dr. Manish De, sir. Dr. Shrikant Atreya, sir. Sir, Dr. Rana Mukherjee. Now I would like to invite Professor Manushi Roy Chaudhuri, Madam, co-chairman of Techno India Group, for giving the overview of Techno India Group.
It's a very good evening to one and all who have gathered here today for such a special cause. And we extend a very warm welcome to each and every one of y'all who have gathered here for this significant milestone in the journey of Techno DAMA Hospital. Today we stand on the threshold of inaugurating a palliative care unit, a beacon of compassion, comfort, and care for those face life-limiting illnesses. Let us welcome on board Professor Dr. Shyamol Kumar Sharkar, Senior Consultant, Clinical Oncologist, Dr. Shrikant Atreya, Consultant Palliative Medicine, Tata Medical Center, and Dr. Manish De, Pain and Palliative Care Consultant, Saroj Gupta Cancer Hospital, Thakurpukur. Dr. Shorab Ghosh, and I'm missing another name. Please, everyone on the platform and dignitaries. So we'll be enlightened to hear from you all. It's an immense pride and gratitude that we mark this occasion for the establishment of this unit represents our unwavering commitment to enhancing the quality of life for our patients, even in the face of challenging circumstances. As we inaugurate this unit, let us not forget the countless individuals whose lives will be touched by the care and support offered within these walls. Let us remember the families who will find solace and comfort during challenging times, and the caregivers whose selfless dedication will serve as a guiding light for us all. I extend my heartfelt gratitude to all those who have contributed to the realization of this vision, our esteemed medical staff from DAMA, our dedicated support teams, our benefactors, and the community whose unwavering support has made this possible. We embark on this new chapter in the journey of Techno DAMA Hospital. Let us reaffirm our commitment to the values of compassion, excellence, and integrity. May this palliative care unit serve as a beacon of hope and healing for all those in need, embodying the spirit of care that defines our institution. Well, this was one part of the new project which we are launching in DAMA. But yes, I have a separate duty also to give a very brief idea about Techno India Group. Techno India Group, which has been formed 4 decades back by the founder chairman, Dr. Gautam Roy Chaudhary, whose main interest was to spread private education, initially in the state of West Bengal, and it started with colleges like Netaji Subhash, Asansol Engineering College, and it rolled on till we got the first private university of the state, that is Techno India University. He had a vision by which he wanted to spread it from the nursery level to the PG level. And so I started with the schools, which could bring about the kids to the units, and they could go out after doing research from the university. But somewhere, Dr. Roy Chaudhary was always inclined for medical education and medical facilities for the state of Bengal. Thus came DAMA Hospital. Yes, for a few years, it was a constructed building, not operating as such, but after almost 9 years, I think it was in 2020, when this hospital started functioning. Dr. Saurabh Ghosh took it over, and I think he actually needs a huge applaud because he was the person who was behind Dr. Roy Chaudhary's wishes so that this hospital starts functioning with the way it should. Step by step, we have gone into different departments, and definitely our doctors from the DAMA hospital will tell about it. But the one which we are recently planning about the palliative care, it's a very new project. It's something I don't think I have to study how many hospitals in the city of Kolkata has this system, but it will definitely be beneficial. And in this aspect, I would also like to add that during the COVID times, when I started with this mental health platform called Monosheets, definitely it started for my students and teachers and parents, but day by day, it was when we realized that the elderly people needs it, the common public needs it, and patients need it. When it's a major operation, when it's a cancer patient, the support, the mental support actually helps us a lot. Just now I was talking to one of the speakers, and I came to know that this is also separately dealt for the elderly people, and I feel that as we are working with Debashish Sen's another project, that is Snehodaya and Shopnobhor. So Monoshrij is working every week. They go to them, they talk to them, and somewhere it's a huge positive change in the last 12 months. We can combine these people also maybe with this project as well, so that we can give them that medical support. Everything will be happening in due course with your blessings, your best wishes, and the positive intention of Techno India members. So wish us all the best, wish Techno DAMA all the best, and it's fantastic that we would hear about what can be done, how it can be done from the eminent speakers on the dais. Thank you so much, and wishing the total seminar a huge, huge success. Thanks a lot.
Thank you, ma'am, for enlightening the audiences with your precious word. Now I would like to request Dr. Saurabh Ghosh, sir, Medical Director of Techno India DAMA Multispecialty Hospital, to give a brief on the facilities available at Techno DAMA Hospital.
Good evening, everyone. It is my privilege to welcome you all, the stalwarts of oncology field in this of this city, and also the budding oncologists who are present here. I am not supposed to speak about the palliative care as such. I am supposed to talk about the facilities present in Techno India DAMA. But still, I can't resist myself from sharing few of my experiences at Thakurpukur Cancer Hospital. I joined Thakurpukur Cancer Hospital in the year 1992 as registrar. On the first day of my joining in Thakurpukur, I was informed to report to Dr. Arunabh Sengupta, the Chief of Clinical Services in Thakurpukur Cancer Hospital. I am privileged to say, it is my privilege that Dr. Sengupta is present here in this audience. Dr. Sengupta, and he is one of the finest head neck cancer surgeon I have seen in my life. Fantastic head neck surgeon. When I reported to Dr. Sengupta during our interaction, I asked Dr. Sengupta, so big hospital, 200 cancer patients, critical patient. I asked to whom we are accountable. He told me, I can still remember his words, you are accountable to yourself only. You may not be able to do, in most of the cases, you may not be able to do anything for the patient. You may not be able to relieve the suffering of the patient, but you will have to be present at the bedside during the critical hours or for the end of life support patient. I think that is the basic teaching of palliative care to a junior doctor, and still now I follow his advices. Another thing, in Thakurpukur, during that time, that was a huge hospital campus, and in the center of the campus there is a big pond with well-decorated garden, landscape garden, trees surrounding the pond, pool. Birds are chirping there, and big white ducks were swimming on the pool. So on the day one, I thought, why these are here? We are not accustomed to see such things in a hospital in Kolkata. Most of the wards in Thakurpukur at that time were surrounding that pond. So I thought, maybe for the visitors when they will come, they will sit here and they will relax. There was concrete benches at the side of the pool. But after a few days, I saw, mainly in the morning and in the evening, morning means at 6 o'clock, 7 o'clock, at that time, patients from these wards with having Ryle's tube fixed on their forehead with micropore, tracheostomy tube in situ, catheter with holding the Eurobag in their hand, they come and sit there. They gossip amongst themselves. They, instead of their sufferings, huge sufferings, they feel relaxed there. I think, to my understanding, this is the holistic approach of palliative care, and that was introduced by legendary oncologist Dr. Saroj Gupta. That is holistic approach of palliative care. Another terminology is coined regarding this palliative care, that is multidisciplinary approach. At that time in 1992, there was no CRM in Thakurpukur, no question of nerve block. Fentanyl transdermal patch was not available at that time in 92. Tramadol hydrochloride was not present. Only pethidine and morphine. These are the two tools or medicines that we use to utilize for the pain killing. With the advancement of medical technology, we have IR, interventional radiology, nerve block, so many tools for pain management. In Techno DAMA, I will invite all the doctors, renowned doctors. You will ask me, why will you bring your patients here? What are the facilities we have for this multidisciplinary approach of palliative care? We have started our palliative care in a separate unit with 10 beds on the first phase, having all the facilities which are required for pain management. We are going to introduce pain management as well. We have all the facilities. I am just showing you the facilities that we have. And I also invite you to see the facilities that we have. You have not yet seen, so I also invite all of you to come one day. That is a glimpse of Techno India DAMA Hospital. Just a short presentation. This is Radha Krishna Murti, and it has been established with the desire of co-chairman in the year 1919. This is our OPD. Reception desk, admission desk. Patient transport. This is our surgeon's room. It is written doctor's recreation room, but this is not doctor's recreation room, this is surgeon's room. Just one thing to say, we have 6 modular OTs. For 6 modular OTs, we need to have a big surgeon's room to accommodate at least 30 surgeons. And this is a fantastic surgeon's room. Those who are surgeons will love to go there, love to have their rest time there. This is our OT. We equipped with all latest gadgets. And all 6 OTs are functioning. To start with, we are operating approximately 18 to 20 cases per day. Orthopedics cases we are doing total knee replacement, total hip replacement. And we have latest C-arms. This is not related to this event. This is our NICU. We have a fantastic NICU, state-of-the-art NICU comparable to any hospital. Even it is comparable to Neutia, which is famous for maternal and child care. We have 8-bedded NICU having all modern gadgets. This is our cabin area. We have 20 exclusive cabins having all facilities starting from refrigerator to micro oven to TV, everything. This is our dialysis unit. We have 10-bedded dialysis unit. We are operating it from 8 a.m. to 8 p.m. and now we have planned to run it 24/7. Our lab services, everything is all major blood investigations, microbiology and biochemistry, everything is being done here. This is our pharmacy. What I was telling about buprenorphine or fentanyl patch. We have narcotic drug license. It is available all the time. So to introduce, to start palliative care, this is also very important. So there will be no problem in starting pain clinic as well. To show some more pictures, this is our 14-bedded ICU. We have another provision for 20-bedded ICU. This 14-bedded ICU is running. This is our gastroenterology department. We are doing upper lower GI endoscopy, at the same time ERCP. Our CT scan, all radiological facilities are available. CT scan, ultrasonography, X-ray. We have not yet started MRI, that is in pipeline. Two things we have in pipeline, one is MRI and another is cath lab. And we are planning to start robotic surgery as well, mainly in the field of orthopedics. That is what we have. That is the facility that we have. We invite you all to come one day, visit our hospital and see what we can do as a whole. All of them we can do a good palliative unit. That's all.
Thanks a ton, sir, for your precious words. Now, I would like to welcome our esteemed chairperson, Professor Dr. Shamal Sharkar, sir, Senior Consultant Clinical Oncologist, ex-HOD of Calcutta Medical College, President of All India Palliative Care AIPC, to give the overview on today's topic in a short.
Thank you everyone. আমার কিছু নেই। দামার ওটা লাগিয়ে দাও। Good evening to everyone, honorable dignitaries in the dais, honorable senior and junior faculties in the audience, and all other participants present here. I welcome all of you in this Saturday evening scientific program. First of all, thanks to Techno India DAMA Hospital for organizing this event. A big thanks to Medical Director Dr. Saurabh Ghosh, Techno India DAMA, for choosing palliative care as a subject of discussion today. It is astonishing to observe that Techno India DAMA Hospital has chosen the area of palliative care to develop from the very beginning of their starting down the cancer clinic, including an indoor facility, indoor ward for patients in need of palliative care. There are many corporate entities and a number of medical colleges that deal with a large number of cancer patients in our city. Barring a few, all these centers in the past neglected the area of palliative care for a pretty long time. As a result of this attitude, many patients in dire needs of pain control and palliative care suffered from uncontrolled pain and other difficult symptoms. Luckily, now things have changed for the better in most of the centers. It is heartening to observe that Techno India DAMA Hospital could start or open a pain and palliative care unit along with dedicated indoor facilities from the very beginning. Thanks to Techno India DAMA group. For the next 5 minutes, I will talk on brief on some important areas of palliative care and pain control, as we are going to open the indoor bed and the OPD and the pain clinic also in DAMA Hospital. Though previously we used to refer our patient to palliative care unit, later at a very advanced stage with uncontrolled pain and other difficult symptoms. But the concept is now changing. Palliative care has now become a specialty where cancer patient can attend from the very beginning for palliation of the symptoms, leading to a better quality of life from the very onset. This is the new development, that patients are attending palliative care from the very beginning of attending their onco clinic. One of the most important areas of palliative care is pain management, control of pain and its associated symptom. So both doctors and nurses should have some basic knowledge, including pain management. Regarding pain management, keeping this in mind, Dr. Monish Dey, palliative care specialist in Soroji Gupta Cancer Center, will speak on pain in advanced cancer patient and its management. You all know the Thakurpukri is one of the institute where palliative care started its function in a very early years. I was in charge of the pain and palliative care unit in Medical College, Kolkata, which was established way back in 1994. And that was the first palliative care unit in the state of West Bengal on a government setting. So on 1994, palliative care started their journey in Medical College. At that time, we used to face much difficulties in having a regular supply of morphine tablet, which is very essential for pain control in these unfortunate patients. The rules and regulations have become less cumbersome at present. We'll have to maintain constant vigil so that our patients do not suffer from irregular or absence of pain control drugs, including morphine tablets, according to WHO guidelines for pain management. So one of the most important necessity in palliative care is group of dedicated nursing personnel. Nursing is one of the vital areas of palliative care, and in my opinion, their role is more vital than the doctors, we doctors. But again, doctors means not only oncologist and anesthetist. We need a functioning MDT, that is multidisciplinary team, that includes physician, surgeon, neurologist, psychologist, and ortho specialists, and all are very vital armament for a palliative care unit. We need a very active, I think this MDT is available in Techno DAMA hospital in plenty. So we need a very active MDT, as some time or other in the last few months of our patient journey, so that they can have a pain-free, better quality of life during the terminal stages of their existence. Today we will hear from Dr. Srikant Atre, Head Palliative Care, Tata Medical Center, Kolkata. He will share his knowledge regarding the state of palliative care in our settings now. Even now, the main obstacle is poor awareness about palliative care and its utility in advanced cancer patients. Among the poor awareness is not only in the public but also in the medical profession. Even the carers, doctors and nurses are often very reluctant to take responsibility of management of these patients in need of control of the difficult symptoms, including pain management. Along with OPD and indoor facilities, Techno DAMA will proceed to have home care facilities for our cancer patient, which is one of the vital area of necessity for a group of patients who cannot reach our institution regularly for various reasons like financial incapability and manpower shortage. Home care team will attend them in their homes so that they can have adequate symptom control and a better quality of life. As we are well aware of that most of our patients in medical college, it's a very important area, and corporate hospital come from rural areas. Most of the patients, a great majority of the patients come from rural areas. We are still lagging behind in reaching this patient with palliative care facilities. In many southern states like Kerala, Chennai, Karnataka, picture is vastly different. Besides trained and dedicated nursing team, they have quite a large number of community health workers who are trained and who are doing a marvelous job as regards palliative care and pain control in their rural community. I have already said that we are still lagging behind in reaching behind this patient with palliative care facilities in rural areas. I am very much interested in developing a palliative care workforce for the rural areas, and we have started working with various rural NGO in this field. Many thanks again to Techno India DAMA Hospital for opening an indoor facility for palliative care patients, and which will be immensely helpful for this unfortunate patient and their families. Thanks to delegate present here and the speaker present here for attending this scientific session and for the patient hearing. Thank you again, everyone.
Thank you so much, sir, for briefing this in such a good way. Now, I would like to invite the entire dignitary to come in front of the stage for the inauguration ceremony by lighting the lamp. Once again, I would like to request MRC ma'am, Dr. Shurabh Ghosh sir, and Dr. Shamal Sharkar sir, and the entire dignitary member to the formal inauguration. Thank you, all the dignitaries. I would like to welcome our esteemed chairperson to be there on the dais as we are starting our scientific session, and the speakers, panelists for also. So it's over to Sir Chairperson, Professor Dr. Shamal Sharkar, for setting the context and purview of the discussion. Thank you, sir. I would like to request the speakers respectively, Dr. Manish Te, Pain and Palliative Care Consultant, Saroj Gupta Cancer Center, Thakurpukur, on the dais, please.
Thank you for the kind introduction. Good evening, respected senior colleagues and faculty members and dignitaries. I am the junior most person, hopefully, I think, of all the speakers. So I am a pain and palliative care consultant in Thakurpukur Cancer Hospital, and today my topic is on pain, the fifth vital sign. So we'll go into the details whether this is a sign or a symptom. So what is the definition given by the International Association for the Study of Pain? So it is an experience, it is an unpleasant experience, and it is both sensory and emotional, and directly or associated with that of a tissue damage. So there has to be a damage, tissue damage, and after that this whole experience starts, which is very unpleasant. And it is very personal. It is different from one person to another. And it has a biopsychosocial model. We'll come into the details later on. Through their life experiences, a person learned the concept of pain. So like we are hurt by someone or something, we try to avoid that, right? So it's a very basic concept, and throughout the life, people learn the concept of pain. A person's experience of pain should always be respected. Whenever a person is saying he's pain, we cannot say ignore that. So it's not a ignorable symptom, we have to respect that symptom. And it has an adaptive role, obviously, but it also has some adverse effects on functional ability and social and psychological well-being. And whenever a person is having pain, he might not be going to his work, he might not be going to his daily activities, might not be able to do his daily activities. So that is the adverse effect. That is called functional ability, which is actually hampered because of pain. And the verbal description actually is only one of the several ways to express pain. Inability to communicate does not negate the possibility that a human or non-human experiences pain. So like an ICU patient who is not able to communicate his suffering, so it's not that he is not suffering from pain. So we have to go into the details of that also. So yeah, so this is the definition and concept. This is the pain pathway. The structure is after a tissue injury, there's an inflammation. There is release of some chemicals like substance P, prostaglandin, serotonin, acetylcholine, and there is a transduction. That's the first step, but the energy, there's a mechanical and chemical energy, is converted to the electrical energy, and it is sensed by the nociceptor, the free nerve endings. And then the next step is the transmission from we all know that first order, second order, and third order neurons goes to the brain. So this is the second step, is the transmission. Third step is the perception in the brain, in the cortex, and fourth step is the modulation, is from the midbrain and the brainstem, where the modulation of pain occurs. So this picture gives you the whole idea of all the painkillers we use for day-to-day activities, like paracetamol acts in the COX-3 in the brain. We use aceclofenac, ibuprofen, NSAIDs, we act in the peripheral pathway, prostaglandin inhibitors. We give steroids also, which are prostaglandin inhibitors again, which phospholipase 2 inhibitor. And we have all the gabapentin, pregabalin, nortriptyline, amitriptyline, duloxetine, all work in the descending inhibitory pathway, acting on those GABA receptors and non-epinephrine serotonin reuptake inhibitors. And we have opioids, morphine, fentanyl, which all act in the supraspinal and spinal receptors in the opioid receptors, and obviously the endorphins, which have natural activities. We, after exercise, we feel, obviously, our pain threshold goes up and where pain sensitivity goes low. So this is the basic picture of all the anatomy, physiology, and pharmacology of pain. And so how will you assess the pain? So it's a mnemonic. We all know Socrates. We all read even in surgery, in pain or swelling, what we see is site, onset, character, and all. So this is very important to understand the area. What is the kind of pain we have? So sorry for the, sorry for the Mac to Windows conversion. Some of the things have been covered. So yeah, so pain assessment model. So site is where exactly is the pain is starting, the onset, and sudden or gradual. Character, is it neuropathic or nociceptive? Is it a burning sensation? Is it a pricking sensation? Or is it there is a swelling, there is a redness, kind of that, radiation to particular areas? Then the associated symptoms. What is the important associated symptoms? Like if there is any swelling along the area of the pain, there is shiny skin changes, it might be CRPS, it might be complex regional pain syndrome occurring in that particular limb. It might be associated with nausea and vomiting. The patient might be in morphine, but there is vomiting. So there's a complication of painkillers also will be included in the associated symptoms, like constipation also. So time and duration is the onset and the duration of pain, which will give you a picture of acute and chronic. And then exacerbating and relieving factors, obviously the activities, walking, sitting, and other activities, lateral positions, lateral postures, which will give you the idea of exacerbating relieving factors. How much time the patient is relieved from the medication, like a morphine, how much time he is getting relief. So this is very important, relieving factors from painkillers, for how much duration. And severity. Severity is the pain scales. So pain scale, we all know, numerical rating scale, visual analog scale, and FACES scale for children. So numerical rating scale is a commonly used pain scale in in-house patients and also in OPD patients from 0 to 10. So 10 is the most patient, and most of the patients will not be able to understand. This is true. I have actually practically experienced in the last 2 years of my practice, very initial stage of my practice, that patients do not understand numerical rating scale. So you have to make them understand. So there are multiple ways to make them understand, like out of 10 rupees, how much is the pain in 5, 6, 7, 8 rupees, or how much is in paisa, in 16 ana, we say, how much ana is how much paisa is the pain. So because this is very important. Why it is important? Because we have a baseline pain severity, and we give some medication, we give some intervention, we actually assess how much it is reduced over a period of 1 day, 1 week, 2 weeks. So this is very important to understand, and we actually skip this part, the severity of pain. This is very important to understand to know the WHO pain ladder, which I am coming to the next slide. So how to assess pain severity is very important for all doctors and all medical practitioners. So NRS is 1 to 3, 4 to 6, 7 to 10, mild, moderate, severe. We all know it, but it is very difficult to practice. When you actually go into practice of pain medicine, this is the most difficult part to understand. Then classification of pain, I will go to the classification. I will not go into the details of the classification because it's a huge classification, primary, secondary, acute, chronic, nociceptive, neuropathic, nociplastic, everything. We are talking about cancer, so we stick to cancer-related pain. So it is 3 parts: visceral cancer, bone cancer, or neuropathic cancer pain. This is given by the International Association of Study of Pain. This is the head body of all the pain internationally. So, and chronic post-cancer treatment patient, like in a post-chemotherapy, post-radiotherapy, it can be post-surgery also. These are the 2 broad classifications, and there is a merger. So this is the merger. Whenever a patient is having neuropathic pain, it might be due to cancer-related chemotherapy. So that is the merger where chronic neuropathic pain and chronic cancer pain merge. So this is where I have to differentiate between a neuropathic pain and a cancer pain, which is due to non-neuropathic in nature. And this mostly happens post-chemotherapy. So this is just a broad classification. Coming to the ladder, and a ladder is basically depending on how you assess the severity, nothing else. If you assess the severity, which is a very tedious job, then you know the ladder is very simple to understand. Mild, moderate, severe. You already know NRS 1 to 3 is mild, and according to the severity, moderate and severe. 4 to 6, and 7 to 10. So we give what we give. Paracetamol, that is the most common medication for step 1, paracetamol, and plus minus adjuvants. What is adjuvants? Adjuvants is like some of the other non-painkillers which are actually helping to reduce the pain. How? I already discussed pregabalin, gabapentin, nortriptyline, amitriptyline, duloxetine, all the anti-neuropathic agents, dexamethasone, steroids when we give reduce the swelling of the patient. So that is adjuvants, non-opioids and adjuvants. Non-opioids includes also NSAIDs. So coming to the opioids, mild to moderate pain, we give tramadol, which is a very mild opioid, and strong opioids for step 3, that is morphine, fentanyl, buprenorphine, etc. And step 4 is the injection, that is the intervention. I will come to it later on because it is WHO has modified the ladder to step 4, and then we actually can reduce the steps. It was not given in the initial WHO ladder. So now we can reduce from step 3 to step 2, step 2 to step 1. So this is the main concept of pain I want to focus on for this my talk, is the total pain. So we only treat the physical part. Most of us treat the physical part caused by the cancer, caused by cancer treatment, caused by the comorbidities, diabetes, diabetic neuropathy. It can cause physical kind of pain. But what are the other 3 factors? We are treating only 25% of the pain with these medications. So psychological, social, and spiritual, all are equally important. It is given equal importance to the whole concept of total pain. So anxiety and suffering, the fear of suffering, the depression from the pain, and the past experience of that illness, those are very important psychological background. So it's a very important, and we also say the patient is having no physical source, it's a psychosomatic pain. No, there has to be some physical mode. It might be percentage will be less, but it's not complete psychological pain. Psychological aspect is present in every kind of pain that is possible in the world. So psychological pain has to be addressed properly. Social pain is very important because the person is, because of pain, he is not going to his job, he is losing his job, he is losing his work days. So there is a loss of job, loss of social status. He is not able to come out to join his social functions. So for him or her, it's a concern. It's a social concern. It's a social pain. So you have to feel that. You have to understand that. And worries about the future of his family. If he is not going to work, then his or her family will be compromised. There will be economic problems. So that is a socio-economic part. And dependence on the family members. So this social pain has to be addressed, history should be taken, and according measurements should be taken care of. A spiritual aspect of pain, we actually don't bother. Actually, the spiritual aspect has 25% of pain in its armamentarium. So anger at fate, anger at God. The patient will be saying that, I don't have faith in God. I do home care scene from Thakurpur Cancer Hospital. I understand what the different religions. I've gone to Christian, I've gone to Muslim households, I've gone to Hindu households, I've gone to Jain households. They have different concept of the spiritual aspect of pain. But you have to understand that. You have to give some positive motivations. So we don't only give the spiritual leaders, chaplains should be there, but spiritual aspect of pain should be understood. So finding meaning, why I am suffering. So these are the things you should be taken care of. So for that we need a team, and obviously the patient and the family is the center of the picture. We have a physician who can be a surgical oncologist, radiation oncologist, who can be a medical oncologist, who can be a palliative care physician. Anyone should be the physician, or all of them. That's the thing. And the nursing staff who is properly trained in palliative care and all the care that is needed. Social worker who should give a socio-economic boost to the patient, either through NGO, either through other methods, so that the patient's economic aspect should be taken care of. That's a big part to play. Chaplain, like the spiritual gurus or spiritual leaders for the spiritual pain. Pharmacist for the medications that are needed for the physical aspect of pain. Occupational therapist, a physiotherapist also for the mobilization. Chest, upper limb, lower limb should be mobilized for the early mobilization and early home. So we have to plan a patient who is there in a palliative care unit. We always plan to send the patient home. That is our primary motto. Why? Because the patient will be more comfortable at home. So for that you need to mobilize the patient. Our good turnovers, good mobilization, patient and the family becomes happy, because that is the center of care. And counselor, psychological counseling should be a very strong aspect of any kind of pain treatment in palliative care. So I will be very short in interventions because this is my armamentarium, and particular intervention I have given in a patient, 48-year-old male who was suffering from CA pancreas and severe abdominal pain, not able to tolerate morphine. So we go for the interventions when there is two possibilities. Either the patient is not tolerating morphine, he is having severe constipations, severe side effects like constipation, nausea, vomiting, etc. And or he might have reached a particular dose of morphine. Beyond that, we are not comfortable to be given. Morphine has no ceiling dose. You can give morphine in 200, 300 milligrams. There is no ceiling dose for morphine. But after a particular dose, there are increased side effects. And obviously, you don't want that. You don't want the patient to be drowsy. You don't want the patient to be constipated. You want the patient to be active in life. That's the purpose of palliative care in pain control in palliative care. So for that, you need some dose modifications. Accordingly, we give the medications. But celiac plexus block is particularly, I have given to that patient because he was not tolerating morphine. And after that, he lived 5 months, and he had to some extent better quality of life than before the injection. That was the target, because we cannot actually target 100% good quality of life in a cancer patient suffering from CA pancreas who is in purely in palliative care. We don't target that. We want whatever percentage he can improve without producing major side effects, so that he can live his life with good quality. Right? So another patient came, ganglion impaired block I've given in a 68-year-old male. He was from Bangladesh, and he had very severe pain. He was not able to sit actually because of the cancer in the lower rectum and the anus. And the surgeons were not able to examine the through PR. So that was a major problem because we couldn't start the treatment. So for that, they asked me for help. I have given ganglion impaired block. After 2 days, 2-3 days, where the actually Kenacott works for after 2-3 days, the initial block I given, the patient was able to undergo the PR exam, and the final planning of the surgery could be done. Surgery and further chemotherapy could be done. And later on, for pain control, before he went to Bangladesh, I gave him alcohol. Because I know the diagnostic block was successful, the patient was planned properly for surgery and chemo, and after that, when the patient was going to Bangladesh for a long-term pain control, I gave him alcohol in the ganglion implant. This is the last sympathetic ganglion of our body. So these are 2 examples I just discussed about. One example I have not included in the slide, I will just tell in front of you. There is a patient who was having a headache, and he was not able to lie down for an MRI. He was having a CA prostate where there was suspicion of metastasis in the vertebra. So we had to do an MRI. We had to lie the patient, but patient was unable to lie because of severe headache in the neck region and the head region. So there was cervicogenic pain. And I assessed the patient who has an occipital headache. I gave a greater occipital nerve block, blind, landmark guided, just outside the MRI suite. After 10-15 minutes, I given only lignocaine, just for the procedure to be going on. So after the MRI was done, yes, there was meds, there was severe meds in the lumbar and the cervical vertebra, but the MRI could be done, and the further processing of the whole treatment could be started. So these are small areas where we worked, and also there are big areas. We gave celiac plexus, ganglion impaired, suprahypogastric, but those are for pain control. But some initiation of therapy also requires pain control, which is not able to be managed with the medications. Those are the areas we creep into, and for the betterment of the patient's holistic care, so the patient treatment can be started. So this is our last example. So I was in a Christmas holiday. I was in the evening. I was free, so I could visit one very young patient, 7-year-old under hematology. He was suffering from severe pain and anemia, and platelet count was low. He was almost critical, going to die maybe on 1 or 2 days. And I was just there. I saw the patient a week before. I just go 2 days in Thakurpukur, but I give my best wherever I go. Try to give my best. So I made myself a Santa Claus, and I went there and reached out to the patient, just hand over hand, and just communicated to the patient's attendants, the family, heard their story, just give 10-15 minutes. That's all. But it was not for pain control. It was just staying with the patient. That's it. Thank you.
Very nice presentation in a very short time. Pain is a very vast subject. Anyway, any question for the speaker? No question, then thank you, Manish.
Thank you, sir.
So our next speaker is Dr. Srikant Atreya, Senior Consultant in Palliative Medicine, Department of Palliative Care, Tata Medical Center, Kolkata. And he will speak on current status of palliative care in the country and in the state.
So I would firstly like to thank Professor Shamal Sarkar sir and also Techno DAMA to invite me for this presentation. And I must say that I have worked with sir since the inception of starting palliative care in district program, district hospital. So it has been a very interesting journey with sir, and a lot of learning and a lot of interaction, and it was amazing. And today, thanks to sir, his motivation, we have palliative care running in district hospitals across West Bengal, and we're still working on it and trying to train and retrain the doctors and nurses in the district hospital. So my presentation is something in extension to what already Manish presented, because palliative care is very essentially pain management, but a lot of symptom management that happens. Ultimately, the goal being to improve the quality of life of patients and the family or the caregiver who looks after these patients. So just a case, like, just an extension to what Manish just discussed. So we have a 54-year-old elderly gentleman, or a 54-year-old gentleman, case of metastatic lung cancer with a spread to the axial and appendicular skeleton, which is the spine. Presents to you with a history of pain of a VAS score of 10 on 10 in the spine, gnawing in nature, present throughout the day for the last 1 week. Pain is localized to the lumbar spine, which is the lower back, for those of you who are not doctors. Pain has been bothersome, affecting his activities of daily living and sleep. With this history, you start the patient on tablet morphine with a combination of antiemetic and a laxative. The patient goes back home and you ask him to review after a week's time, but the patient returns to you with a pain score of 50% reduction. Now, statistically, if you see, it is a very significant reduction, but clinically, or from the patient's perspective, it may not be great. So, as palliative care physicians, pain physicians, we have a lot of role to play with patients, pain control, symptom control on an ongoing basis, because pain could have multiple facets to it. It could be physical, definitely most important, psychological, social, and spiritual, and all of these can kind of aggravate pain or the intensity or the manifestation. So this patient that we discussed about could have any of these factors, and it's not that one factor gets over, the other one begins, but it could be a combination in whichever permutation and combination you think you would want to look at. So it could be a physical pain, it could be anxiety related to a 54-year-old gentleman having an anxiety of recurrence, fear that he might have to give up on his job, and what about his children who are just graduating from a college. Or it could be, if it's like some patients come to them from the rural or tribal background, could be having stigmatizing effect because of cancer, where they are just told that, okay, cancer would spread, so don't even interact with us. So it could be socially stigmatizing. Extreme financial burden, because we have cases where families have sold their property, their land, for treating their patients, have gone to Apollo Chennai, or they've gone to TMH Mumbai, lived there on the street, just so that the patient could be treated. And something like Manish just spoke about, something that we just ignore. Although we know it's very essential, and today we speak a lot about spiritual quotient. For all of us, it's not just about the patient, but for all of us. But for us, it's temporary, it's dynamic and fluctuating. But for our patients, it's almost a permanent phenomenon. Could be dynamic, but the graph is just there. Why me at all? Is a question that all of us have faced in our lives, but we often find solutions, we find solace to it, and we are better. But patients don't get it. And some of the patients really, when they start thinking about their families, when they start thinking about having to give up on their job and the financial burden, it's like, what is the purpose for them to exist when they're going to be so dependent and liable on the families? So these are some of the questions that keep bothering them every time. So that's why Sir also put forth that it's essential that we have a multidisciplinary approach to caring for the patient. It is not just about a pain physician, it's not about a palliative care physician, but about a nurse, a sociologist, a psychologist, maybe physio or occupational therapist, who need to be a part of the team when caring for patients with cancer, non-cancer, in palliative care, or end of life. Now, it's essential to know here that we just spoke about the patient, and when we talk about caring for patients, or when we talk about providing treatment to the patients, often we forget the role that family caregivers play. And a lot of anxiety is rather driven into the patients, or the patients drive a lot of anxiety into the families, because we need to look at treatment with the patient and the family as one single unit. It can't be only a patient, it can't be only a family. Now, why am I saying this is, when we talk about only a patient, we need to understand that families are going through the distress of the treatment and the prognostication. When we talk about only the family, many times we collude. We don't want to prognosticate to the patient because the family says so. So it's important that when we discuss prognostication, we discuss the diagnosis, let's forget the prognostication, it's important that patient and family be a unit there. It is just about time for us to actually understand that non-oncology palliative care is the need of the hour, but we are focused a lot on oncology because that's where people have the misconception that, oh, cancer, palliative care is attached to it. But non-oncology patients require a lot of palliative care. But considering the cost of treatment, considering the inaccessibility to care, to a tertiary setup like Tata Memorial or Techno, DAMA, wherever, the inaccessibility, the geographic distribution of the patients, it is extremely difficult for us to reach out to the real, difficult families and patients who are not able to get it. So we are going to have, by 2060, malignancy is going to be the topmost in its incidence. So we are going to be having a lot of palliative care, a lot of, combined support with oncology and palliative care, still going to be going really strong in the future. Now, what about symptom burden? So Manish just spoke about pain, but pain is one of the very essential symptoms that not every patient, at least 70 to 80% of patients with palliative care needs, or even 90% of patients at end of life might have pain. But what we need to understand here is that there are other symptoms as well that happen and that really needs to be addressed when we look at it. So when you look at physical symptoms, this is a graphical representation, not just talking about cancer, but also about other diseases. If you see, cancer, COPD, and AIDS have the highest symptom burden as compared to other diseases. And among the symptoms, it is actually anorexia, which is loss of appetite, followed by pain, followed by fatigue, which really cripples patients and their families. So it's important that when we address, it's just not that pain and pain and pain, and that there ends the matter. Because many times, when people talk about palliative care, it's either, end of life care hai, chhod do wahan pe. Yeah, it is like pain management hai, anesthesia ke paas bhej do. But palliative care is about entire spectrum. Like what we saw here, major concern is appetite loss. The major concern is fatigue, followed by pain. So we need to kind of address every aspect, like a holistic support that we talk of. We need to look at it. On the other side, we have psychological burden. That's often unaddressed, often untouched, because that's not my area, so let me not tread there. So often that happens where physicians don't feel, either because they don't have time, or because they feel that is not something which I'm trained in, so I would not look at the psychological aspect. But you need to understand that when a patient presents with symptoms, it's also the patient's anxiety driven into the symptom that we need to look at and to be addressed as a holistic approach. Now, this is all tangible. We have a scale, we assess a scale, the spirituality, we can assess a scale for, anxiety, depression, we have a scale for pain, like a SAS score. But what we don't really understand is suffering. Suffering is not something which is tangible. Suffering cannot be something which is like, kind of, it has a plateauing effect. It is always a fluctuating dynamic effect. So something which we really fail to address is the meaning that patients or families attribute to the disease that they have. And that is what is suffering, and that is what is the main cause for concern, because that is what causes anxiety, that's what causes depression, non-compliance to treatment, non-adherence to your therapies. So this is what we need to look at as physicians sitting in the OPD, and maybe refer the patient to the psychologist or a sociologist who can really kind of go into the depth of it, delve into the problem, and address it equally much. And the suffering could just not be physical, that I have a pain, but it could be the fear of impending death, the fear of having cancer, and rising symptom burden could be the meaning of what they go through. Even loss of autonomy or control. How many of us, here want to have the power? I am the most superior and I look after everything out here. But when the patients lose that autonomy, when the patients lose control over themselves and the surrounding, geriatric population, they lose control of the surrounding. All this while they were taking decisions for themselves and the family, and suddenly they have lost control. That is kind of very distressing. So a constant sense of insecurity about the future. 54-year-old gentleman, am I going to be cured? Am I going to have the cancer recurring? Am I going to be supporting my family for the future? Who will support me or my family if I were run down with a bad disease like this? So this is a constant sense of insecurity, and this is what we need to kind of address in addition to physical symptoms. Now, I'm not going to the details or definitions of palliative care, which you can Google, and Google is the best site for it. So, but what I want to just convey here is the misconceptions about palliative care that still exists across many minds is palliative care is end-of-life care. Please remove that and discard it, flush it out, do whatever you want, but flush it out. Palliative care is about improving the quality of life. It does not say that it's going to cure the cancer, but it's going to definitely say that I will be there with you while your treatment is going on. And it controls the symptoms. It could be physical, psychological, social, spiritual, through a multidisciplinary approach, and ensures that patients and family as a unit sail through this difficult journey peacefully. And that's what palliative care entrusts in the patients. But we talk a lot about palliative care, and interesting and fortunately, we have palliative care across now, Techno, DAMA, Tata Medical, Thakur Bokar, everywhere, but we still haven't achieved much because we have a lot to achieve, because we talk about major cities in the country doing it, but when I talk about my patient coming from Nadia or Midnapur, I am lost. I don't know what to do. We have good home care teams that can support, but what about patients who go back to Midnapur and Nadia? I don't know. And that's what it says. 40 million people in the globe need palliative care each year, and 78% of them actually live in our own countries where there is no accessibility to palliative care. We try our best, everyone, like Sir is trying his best, everyone is trying their best, but we still are not able to reach there. But I'm sure at some point we will be able to. It's not just our problem, it's a global issue, So, as I told you, palliative care is not just about, end-of-life care and terminal care. Of course, it plays a very vital role in end-of-life and bereavement. So, it's not that it is discounted, but it's a very important role that it plays. But what's important to understand is palliative care can be integrated right on from the beginning, even before the diagnosis of cancer. So I can give you an example. I hope this works. Does this work? Does the pointer work? I'm sorry. Okay, you can look at till the time that works, but if you look at figure 3, let's start with figure 3. So that's where palliative care can be initiated. I'll give an example, a case example. So we had a patient who had come from Bangladesh, and she was not diagnosed, but she was suspected to have a lymphoma. She presented to us with intestinal obstruction. Of course, then the surgeons were referred to. The surgeons said that she's inoperable, so we cannot do anything about it. Then the patients were referred to palliative care team if we could manage the symptoms, and almost deemed inoperable, incurable, not treatable. So then she was referred to us. We looked into the symptoms. We provided a combination of medications. Her bowel movements improved. Then she was transitioned onto hematological malignancy treatment. So many times it is not just about end of life, but also this patient could be transitioned. So why am I talking about this? Because it is motivating to note that it can really help patients move on to their disease-directed treatment, which is so essential for them. And that's exactly what they come to you for, right? I can give you a second example is figure 2. So figure 2 is actually about a patient who was undergoing disease-directed treatment, chemotherapy. And as we all know, chemotherapy causes a lot of side effects, and often it happens that the treatment is aborted because the patient has severe neuropathy, or the patient has developed severe intractable nausea or vomiting despite all medications being given. So the treatment is aborted. But what we do is, how does palliative care pain management help? Managing the neuropathy. Now, treatments, there are medications that really help control the pain symptom. There are treatments to control nausea, vomiting, and other symptoms. Patients get better. They move on to their oncologist to get their chemotherapy or continue the treatment uninterrupted. So that way, palliative care can be initiated right on from the beginning. So that's where palliative care can come either in the beginning, it can come in a pulsed manner, or it can come in a classical Google picture, which is end of life, where palliative care has a role in end of life and bereavement support. So in short, if I say palliative care is like an umbrella of care, it provides support, or you can say even a cloak. So the main word palliative care, palliative means cloak. So it does not say that I'm going to cure your cancer. It does not say that I'm going to prolong your life, but it just says that I'll support you through the journey. And that's why palliative care need not be initiated at end of life. It can be initiated right from the beginning. And that's what we need to advocate to our oncology colleagues, our surgery colleagues, our non-oncology colleagues, the neurologists, nephrologists, all of them, so that they understand the essence of palliative care and integrate it into their team. And that really helps not only you, but also the patients and the treating physicians. So I'm not going to the details of any of these studies, but just to say that there are evidences, I'm not talking off my head, but there are evidences to prove the beneficial effect of initiating palliative care at an early stage. And the most classical paper is Temel et al. Paper, which I'm not sure many of you might have read, where there has been, although a marginal difference of 15%, but there has been a difference in the survival, and there has been a prolongation of life in patients where palliative care was given concomitantly with disease-directed treatment. And of course, when your symptoms are managed, families feel comfortable, patients feel comfortable, the satisfaction levels are better, the anxiety levels go down, the compliance to treatment improves, and their acceptance to end-of-life palliative care also increases, because as they transition on to end-of-life, they don't look at a palliative care team as strangers. They look at them as one of the integral members of the team who's supporting them through the journey. And their acceptance and the chances or the probability of them getting onto ICU and ventilator is almost nil. So we could have a palliative care model. So I guess I'm not overshooting the time, sir. I have just last slide. So yeah. So palliative care, can we just wanted to explain this model to you. It's like palliative care can be provided in multiple ways. When people talk about palliative care and how to provide it, the roadblock and mind block is that, we need to have a multidisciplinary team. We need to have so many people to work with us. No, we don't need to. When we started off palliative care in Tata Medical Center, it was me, and before me, Dr. Datta, who was our psychiatrist in our department. He and I started working on it. And slowly we started kind of pulling in people, getting in people, and then now we have a full-fledged inpatient palliative care unit. We have a separate hospice unit where we provide care to our patients on an ongoing basis. So palliative care could be an independent clinic. Like for example, you could have an independent clinic. The advantage of an independent clinic being every patient who needs palliative care, not necessarily only oncology patients, gets the benefit of it. So it's not that it's an oncology-dominated care that we need to provide. But there is a disadvantage to it, is that not many referrals do come in. So many times, palliative care physicians have to kind of come out of their comfort zone and go to the clinicians and say, boss, refer. Boss, do this for us. And we need to do it for our patients. Embedded clinic is like what we have in Techno DAMA, where we have a palliative care clinic embedded in the oncology unit. So it's easier because you have the palliative care team introduced to the oncology team and their patients through an MDT, and it's just a part of the care which is being provided. So it is a continuum that is there, of care, and that is very helpful for the patients. But often the disadvantage being that in the process, unless again the palliative care physician and the team kind of is not very aggressive, other patients who might benefit, like for non-oncology, nephrology patients or neurology patients who might benefit, may not get the benefit of palliative care if they just feel complacent that, okay, fine, I'm providing oncology care, I'm happy about it. So often this is the advantage and disadvantage. Thank you. Thank you for your time. Any questions?
Thank you, Srikanth. We are.
Please. Yeah. Do you want me to depict it again? Yeah. Okay. So basically, that was a multiple level obstruction because of the lymphoma. So we gave a combination of steroid with prokinetic agent, and also an antacid, so that that can improve the bowel movement. Like we gave a PPI often, so that improved the reduced the head swelling, the edema, and it improved the prokinetic, improved the bowel movement, and that's how the patient responded within 48 hours of starting the treatment. Yeah, metoclopramide. We gave it as a higher dose of continuous infusion, as a continuous IV infusion through the syringe driver, and that improves the kinesis and relieves the obstruction. We start off at 4 milligrams twice a day. Yeah.
Thank you, Dr. Srikanth, for a very nice presentation. So we are running short of time. So otherwise we could have continuing discussing palliative care scenario. So our next speaker is Dr. Anna Mukherjee. He will speak on community palliative care. We are already running late, so maintain the time span.
Good evening. It's always difficult being the last speaker. There are various other things that occupy people's mind, primarily about going home, having food. So I think even the speakers, 2 of them have left. So it is something that I will keep in mind. We heard a lot about what palliative care is and how it can help people. I will speak a few words about what we actually do for the patients in the community. It is always a different ball game when you are taking care of patients in the community compared to within the confines of a hospital. Now, I'll start with something that is very unusual to be spoken of in a palliative care. In the prehistoric times, culling of the unfit was practiced. Anybody who was unwell, chronically unwell, would be culled, left, abandoned. After that, in certain ancient communities, they would be abandoned, but with rituals. The Eskimos, they would build a small enclosure and keep the person who was unwell in that. The first sign of civilization, actually it is considered to be first sign of civilization, is when communities started looking after people who were unwell or injured or chronically unwell. And then the transition came to the community-based neighborhood care. It was the community and the neighborhood that took care of these people. And finally, the organized care by professional organizations. So this is just a historical, Now this is, palliative care is defined in many ways. This is what I found to be very nice. It explains how I consider palliative care is to be. Palliative care aims to prevent and relieve health-related suffering of adults and children, along with their families. Very important. It's not only, palliative care is not only about the patient, it is about the patient and their families, facing problems associated with incurable or life-threatening illnesses. It is based on comprehensive and personalized approach it's very important again, personalized. It is not a blanket care. It is personalized for each patient. And addresses the physical, psychological, social, and spiritual sufferings by mitigating symptoms. I think the aim of palliative care is to mitigate. You cannot cure, you cannot end, you cannot completely remove the suffering, you can mitigate. I'll move on quickly to our model, which we practice. I was glad to hear about the MDT being mentioned a number of times. I think in the community, over the years, what we've been able to do is to develop an actual multidisciplinary team comprising of doctors, nurses, physiotherapists who have special training in palliative care, and psychologists, movement therapists. So we use multidisciplinary team as it is supposed to address various facets of a palliative care patient's requirements. So we always start with an assessment, and we have been told repeatedly, why do you need an assessment? I can tell you what the patient has. But answer is that you can tell me what the patient has, but you do not know what the patient needs at home. You are seeing the patient in a clinic or in a hospital with that setting. But it's important to know what the patient needs at home. And we then can fit the right kind of caregiver to the patient and sensitize the caregiver about the specific requirement the patient has. We always try and minimize invasive investigations procedures. We have got used to doing a lot of investigations. We have almost become dependent on those. We try and minimize that. And we continuous process of engaging family to accept what is happening. You see, the patient is on many occasions have a sense of acceptance because they're undergoing the problem. It is the family who we find have a greater degree of resistance to acceptance. They are the ones who fight. They are the ones who insist that something be done. Why are you not doing anything? So we try and engage them continuously. We liaise with external or in-house palliative care specialists. We've been working very closely with Shrikant for his patients in the community. One of the things that we do, which has not been mentioned because it's very, very unmedical, if I may put it, we elicit and try fulfilling last wishes. This is something that we have found gives a huge amount of satisfaction to the people. And I thought I would be speaking about it later, but to cut it short, I'll just mention a few. One lady was very unhappy and she was very depressed because she felt that she was coming to the end of her life and she would never be able to taste mango again. She had a esophageal CA and she was not being able to swallow. So we did something very simple. We bought the best mango possible, took it to her, asked her to chew it, swish around in her mouth, get the taste again, get the smell again, and spit it out. But that itself, this simple thing, made a huge difference to the patient. And we always look at the whole of the patient rather than the patient's individual symptoms. Another lady, very feisty, very independent to the last days, wanted to wear a red t-shirt for some reason, just a red t-shirt. And getting that for her itself was wonderful for her. So these are the kind of things that we do. We counsel a lot about letting go. I think all human beings find it very difficult to let go and consequently suffer a lot of pain because they are forced to let go. So we do a lot of counseling, and just as a, even with a multidisciplinary team that has psychologists, we found that requests for psychological counseling or help is very few and far in between. So we tried understanding why this is. We felt that people in the community, people who prefer to stay in the community, are homebound. And they don't really like too many strangers coming and telling them what they should or should not do. What we have done instead is to repeatedly sensitize our doctors, our nurse supervisors, our caregivers to do the kind of counseling, especially about letting go, about the thing that it is inevitable, but we are trying to help you make the best of it. And I think we have found that that works very well. We have tried to ensure a dignified death in the presence of families. A lot of people have told us specifically that we don't want to die with tubes sticking out of us and alarms ringing all the time. And finally, we also try and do bereavement counseling where required. We remember a 34-year-old woman who died, who had 2 children. One was just approaching a teenage, and the other was, I think, 6 years old. And the father requested for giving them some counseling, and this continued even after the mother passed away. Briefly again, the challenges that we face in the community, that is different from that we face in a hospital setting. The family members' presence, while it is a boon from one side, having the family around you, it is also difficult because the family is continuously seeing the suffering and they're reacting. They are either very, very unhappy, sad, angry, all the levels of acceptance. And they continuously pressure us to do something. Kichu korun. That's oh, khub koshto pacche, kichu korun. And that is something that is a challenge. Their concerns are genuine. It's not that they're making it up. And we do not actually have answers. But it is just a question of hand-holding, being there. Another challenge in the community is the difficulty in getting USG-guided procedures. Because of the PNDT Act, you can't get USG guidance. Venous access is another big problem because the chemotherapy has already taken care of the veins. So a lot of time we have to give subcutaneous fluids, which is not ideal, but we do. Procuring narcotics is still an issue. And what we have done is we have 2 regular suppliers at 2 ends, south of Kolkata and north of Kolkata. And if we find that the family is unable to, or we are unable to get it from the neighborhood areas, then we procure it from them. And then finally declaring death and providing death certificate. That is something that as a community-based team, we find it quite difficult. But again, we have found that counseling the family from beforehand and saying that these are the logistic problems that we will be having makes them understand, even when it eventually does happen that the patient passes away. If we cannot provide immediate death certificate, it is something that they can understand. I think, as I said, we are really running late. So I'll just rush through a few slides. Fulfillment of last wishes. This lady wanted to have tea. And you can see the concentration on her face when she's looking at it. This gentleman on the left continued to read his paper till the day he died. Even on the day he died, on the morning, he was reading a paper. This lady actually died of frailty and a broken heart because of the behavior of her family members. She just withdrew. But before she did that, she had come to our office. She wanted to see our office, and she wanted to meet the whole team. And that is what we were doing. So the one on the left is really poignant. The lady was on her deathbed, and she just wanted to see her son's marriage. So we arranged for a very basic marriage with exchange of garlands in front of her, and again she died a relatively happy lady. There are many such stories, and we've had MND patients who've been with us for a year and a half. They came to us when they had just stopped being able to breathe. So they were on ventilation for a year and a half. When he passed away, he was just a skeleton covered by skin, but he had full mentation. And handling such patients is very, very difficult. I think I have given you some idea of what palliative care in community is about. And if you have anything to ask, I would be happy to.
Thank you, Dr. Mukherjee, for keeping it short and lucid. I think there may be one or two questions. People are very eager to start their next journey.
Heartening that families are really satisfied at the end of the day that the doctor was there, the nurse was there with them by their side. I guess that's very important.
Shrikant was mentioning about his journey. I think we have had a parallel course. Shrikant started off in TMC. We started off in the community. And I think we have collaborated to develop the model that I was talking about. I think he has had a big role to play in that. And I believe we have had some role to play in his journey in palliative care as well. Thank you.
Thank you. With this, we thank the participant here, the faculty is here, the speakers here, and we now conclude the scientific session.
Thank you all. I think it was a wonderful session. We are grateful to all the eminent speakers and of course the chairperson for setting the stage. So on behalf of Techno India DAMA, I would like to appreciate all the dignitaries. As we are running late, so dinner is ready, so enjoy your dinner. Good night. Thank you once again.